complications, and he's been involved in lots of clinical trials, UK Chief Investigator for AVERT and Interstroke, and he will address the issue of blood pressure in relation to cerebrovascular disease. Peter.
Thank you very much. I thought you said our secret was safe. Thank you very much, Chairman. It's a great pleasure and honour to be invited to present here. Although I must say I'm a little anxious because I'm not a hypertension specialist, and a number of the big beasts of the area are attending this meeting. So what I decided to do was to approach the topic of, as a clinician with an interest in evidence-based practice, and say, how, as a user of the evidence, how does it help me with everyday decisions? And so what I wanted to do was look at the topic of the management of cerebrovascular disease, and rather quickly review the areas that we know, and then focus on areas of uncertainty that certainly are relevant to my practice. And kicking off with areas that we know, this audience will be familiar with a lot of this information, but I think it's quite useful to reflect on just how much evidence we have to guide our decision making. And firstly, I mean, it's clear that hypertension is the primary risk factor for stroke. I think the Interstroke study, a big observational study, is going to confirm that across 30 different countries. It's far and away the major risk factor. But it's also pretty clear, if you look at all the trials in the sort of elderly population, all the blood pressure lowering trials, there's a very convincing net reduction in stroke, cardiovascular disease, and all-cause mortality. It's pretty clear, if we want to prevent stroke, blood pressure is the primary risk factor to be addressing. And even when we go drifting more into my own area of practice, into the if you like, the very elderly group, the older old, the pattern is still very convincing. And again, this won't be news to this audience, but you certainly get a net reduction in stroke and cardiovascular outcomes, possibly not a net reduction in all-cause mortality, but still, if you're looking at trying to prevent morbidity, even in the older age group that we used to write off, there's a very convincing evidence that we should be reducing blood pressure. Once you go into a bit more detail, I mean, this is looking at people with different background histories, with no history of vascular disease, coronary artery disease, or a history of stroke. And this is, of course, the prevention of coronary heart outcomes and stroke outcomes. And it's pretty clear that the previous history doesn't particularly matter. We should be lowering blood pressure. And at the risk of drifting in maybe into a more controversial area, I think the drug of choice probably is not the crucial decision in terms of preventing stroke. I'm aware that some of the data in the stroke prevention literature is a bit variable, but when you look at the information altogether in terms of in this case, reduction in systolic blood pressure versus the reduction in stroke or cardiac outcomes, the picture is quite convincing that the more you can reduce the blood pressure, the more you can reduce the stroke. And for a particular blood pressure reduction, you'll get more of a bang for your bucks in preventing stroke than with coronary heart disease outcomes. So we're really very well provided with information. And some recent work which is looking further at this, the issue of the degree of blood pressure reduction versus the relative risk of stroke, I think just confirms again this pattern of the more that you can reduce the blood pressure, the more you'll reduce the stroke. And I think one of the things that's come in over my sort of career is the relative unimportance of the pre-treatment blood pressure, or that the benefits of blood pressure reduction are seen across a range of baseline blood pressures. So an awful lot of information generally on the prevention of stroke through blood pressure management. Once we get into the more specific area where stroke physicians are working, then we've got less information, but we've still got quite a lot. This is the value of blood pressure reduction in people who've had a recent stroke or TIA. It's a recent meta-analysis by Peter Rothwell's group, and showing that highly significant reductions in stroke risk with both with diuretics and the angiotensin system drugs. And of course they showed, as was alluded to in the previous questions, a bigger reduction with the diuretic group of drugs than with the angiotensin inhibitors, but this was probably a blood pressure effect. And then finally, I'd said that hypertension is the primary risk factor for stroke, but if your index event is cerebral hemorrhage, then the picture is even more greatly magnified. And for people who've got a history of cerebral hemorrhage, tight blood pressure control is absolutely essential. So I think you could begin to think maybe we've answered everything. But of course, it's when we get down to the very practical questions about how quickly, how hard, how fast do we go in with blood pressure reduction in somebody who's very recently had symptoms. And most stroke physicians are relatively comfortable about early blood pressure intervention in people with TIA who've got no persisting neurological deficit. But if you've got someone who's got ongoing neurological impairment, then this is where the problems begin to arise. And of course, this audience will be very familiar with the traditional graph about mean arterial pressure against cerebral blood flow, and the idea of cerebral autoregulation maintaining a constant blood flow between about 60 and 150. And the strong belief that in cerebral injury like acute stroke, you lose this autoregulation and cerebral blood flow becomes very pressure dependent. And that's what I was taught at medical school. And in fact, in terms of clinical experience, this does seem to hold true. There's one area, the phenomenon of early neurological deterioration, also called stroke progression, which is, I think, quite a well-recognized phenomenon. About 1 in 4 acute stroke patients will show an increasing neurological impairment between arriving at hospital and the first sort of 72 hours. And if you have that pattern of increasing impairment, you will also show a pattern of more extensive brain injury on the MRI scan. And there's some well-established risk factors. People with hemorrhage are at higher risk. The bigger your stroke, the worse it is. Older, frailer people are more at risk. And there's a number of physiological abnormalities seem to put people at risk of this this progressive ischemic change. And there's been quite a lot of work done on these risk factors, and one of the ones that have been of greatest interest has been blood pressure in the acute phase. And this is where it begins to get a bit complicated, because of course in your normal stroke patient you will have a raised systolic and diastolic blood pressure that will drop, on average, about 10 or 20 points in the first 24 or 48 hours. And there's been a lot of work done trying to establish if that is the ideal, or if that's something that is pathological that we should be interfering with. And I'll begin just with some of the observational studies. And this is, these two graphs show a lot of observational data, some from Philip Bath's group and some from the big SITS register, showing that simply on observational data, if you plot the risk of a bad outcome, this is death or disability, versus your baseline systolic blood pressure, your lowest risk of a bad outcome is when your baseline systolic is about 160. So that's immediately after your acute stroke event. And a very similar pattern seems to be seen among people who are treated with thrombolysis. But the picture, of course, gets more complicated because it's a dynamic phenomenon. And this, I'll just explain this. This is a kind of three-dimensional graph which shows the admission systolic blood pressure in about 1,500 stroke patients. And it's plotted against what happened over the next 24 hours. Did their blood pressure drop or rise? And then what they did was they plotted each patient outcome in terms of their chances of being dead or disabled. And a dark outcome is a high risk of death or disability, and a pale one is a low risk. So pale is a sort of better outcome. And what this group showed, this is a study from Switzerland, showed that the best outcomes were seen in people who started with a systolic blood pressure between about 130 and 160, that then dropped by about 10 or 20 points, maybe slightly more, over the first 24 hours. And people who started with a very low blood pressure, a very high blood pressure, or whose blood pressure rose in the first 24 hours, they all had a poorer outcome. So there was a strong indication, from the observational studies that there are certain patterns that may well be associated with poorer outcomes. And the picture gets even more complicated when you actually look at the dynamic pattern, because in each individual patient you'll get very variable blood pressure in this acute phase, and a high degree of variability is associated with early infarct growth. So there's a lot of observational data suggesting that ideally what you want is someone to have a modestly raised blood pressure that comes down smoothly over the first 24 or 48 hours. And that, of course, has led on to a lot of the drug studies looking at early intervention, trying to bring blood pressure down in the acute phase. And again, Philip Bath's group at Nottingham have been very active in this, and they reviewed all the trial data looking at active blood pressure lowering this is up to about 4 or 5 years ago. And I've just shown the graph summarizing the data by the different drug classes in terms of the reduction of death or disability. And overall, across all the classes, there was no significant impact with blood pressure lowering therapy in acute stroke. And Philip Bath's group went to further explore this and plotted, now this is the blood pressure drop, or rise in fact, but mainly blood pressure drop observed versus the odds of a poor outcome, death or disability, and showing, just emphasizing that if there was going to be any apparent benefit from these trials, what you would want is a small blood pressure drop in the acute phase after stroke. So that really led on to a couple of studies which many of you will be aware of. The first one was the Access study with candesartan, which led on to a big Scandinavian study which looked at the Scandinavian candesartan acute stroke trial, which looked at candesartan given to acute stroke patients within the first 30 hours of stroke. And their primary outcome was a composite vascular endpoint. They also looked at death and disability. And they showed a modest reduction in blood pressure over the first few days and no difference in their primary or secondary outcomes. And when they went on and looked at this in the context of all the previous blood pressure lowering studies, and this is the Scandinavian trial here, which has about the same amount of data as all the previous similar blood pressure lowering studies, is a remarkably consistent picture of really no convincing effect, or if there is any reduction in death or disability, it's going to be of a relatively small scale. So by 2012, was that the end of the story? Well, not quite, because all the studies I've presented either looked at exclusively acute ischemic stroke patients or with patient populations with only a small number of a small percentage of cerebral hemorrhage. And one of the phenomena that's increasingly recognized in recent years in cerebral hemorrhage is the idea of hematoma growth. And this is demonstrated very clearly here, that if you can scan cerebral hemorrhage people quickly enough, you will, in a substantial number, record a rise, an increase in the volume of the hemorrhage. And one of the key risk factors, probably the primary risk factor for that, is their blood pressure. And that led to the Interact pilot study, looking at a surrogate outcome of hemorrhage growth. This is a percentage hemorrhage growth in two groups. One group randomized to the guideline blood pressure management, and the second group randomized to more intensive blood pressure management. And in their pilot study of just over 400 acute cerebral hemorrhage patients, they showed a significant reduction in hematoma growth. And that then led on to the main Interact 2 trial, which was just reported this year. And just to remind you, this was a trial, international multi-center trial, recruiting hypertensive people with spontaneous intracerebral hemorrhage. The standard blood pressure management said try and get the systolic below 180. Intensive regime was to get it below 140. And they looked at 90-day outcomes. And they recruited about just over 2,500 participants from a large number of countries. And the picture is quite complicated because it was a strategy of blood pressure reduction rather than a particular agent, and so a whole range of approaches were used, varying between countries, between centres. Predominantly alpha antagonists, I think nicardipine, with labetalol and GTN were the commonest agents used. And there were quite substantial differences in the blood pressure management approach between the intensive and the standard care groups. What they were trying to achieve was to get the target blood pressure in the intensive group under 140 systolic within 60 minutes. And in fact, they only achieved that in about a third of patients, and a half got there within 6 hours. But there were still highly significant differences in the blood pressure pattern between the intensive regime and the standard care regime. Now, their primary outcome was the odds of death or disability, and this is defined on a ranking scale of 0 to 2. They had a dichotomous outcome. So that's basically independent and personal care versus disabled or dead. And at their intention to treat analysis, unadjusted, was significant at p is 0.06. And the adjusted approach was less impressive. And they looked at a range of other analyses, which all sort of teasingly balanced around the sort of p is 0.06 result, p-value. They did have one pre-specified outcome. It's an ordinal shift analysis. If you're not familiar with this, it's rather than saying, do your patient group get over a particular finishing line, you address the question, do they, on average, have a better distribution of outcomes, so fewer severely disabled, more moderately, more independent. And this was significant as p is 0.04. So the conclusion from Craig Anderson and the trialists was that we should be implementing this approach in acute intracerebral hemorrhage because it's safe, because it's effective, consistent direction of effect, no heterogeneity of treatment effect across different patient disease characteristics. And his conclusion when he presented this just earlier in the summer was go early, go intensive, go sustained. But the presentation really raised a lot of uncertainty in the audience about how confident to be in terms of the trial results and implementing quite an aggressive management strategy. And so for a sort of jobbing clinician like me, confused by the evidence, what should I do? I think if you go back to the current, as unrevised European guidelines, they're fairly cautious. They're suggesting don't routinely lower blood pressure, certainly not in acute ischemic stroke. If you're going to lower blood pressure in severely hypertensive people, have a reason, like hypertensive encephalopathy. That lowering should be abrupt lowering should be avoided. There's a recommendation about treating hypovolemia, which I think is not based on much evidence, but most people would do it. And then there's this area around the management of blood pressure in thrombolysis, which is essentially all based on observational data, and there's quite a variation in practice. So what you currently do since the Interact study, I think depends whether you're a rather aggressive early adopter or you're a more thoughtful sort of neurological type who's a bit more circumspect in the way that you approach trial evidence. Fortunately, there's a lot more information about to come out. The Americans, as they usually do, had their own version of Interact 2, and that's not yet finished, but will finish shortly. Philip Bath's group in Nottingham have the ENOS trial that's about to hit 4,000 participants. That will be a big contributor. There's also they're also looking at a very early ambulance protocol. And then the Australian group are looking at a randomised trial of blood pressure reduction in thrombolysis. So I think unusually for us stroke physicians, we've actually got less to whinge about just now. We've actually got quite a lot of evidence coming through, and I hope that we'll have a lot more information in the near future. Thank you very much.
Thanks, Peter. Now, we're very tight for time, and I'm conscious of the 5-minute walk now to the coffee area. Is there maybe just one burning question? Because I'm sure Peter would be happy to take questions at the coffee break or during the walk over. One question.
Yeah, I just wondered, maybe you think it's a bit of a joke, but the pressure in the brain depends on your position, and when you stand upright, it's incredibly low to when you're lying flat. So why are people with cerebral hemorrhage kept lying flat? And it would be much more sensible to keep them upright, wouldn't it, if you wanted to lower their...
That's a very good and a very topical question. And a lot of the practice is driven by studies of like transcranial Doppler flow studies of people, lying flat or sitting up. It's all based on kind of surrogate data. However, there's a trial, AVERT, looking at very early mobilisation of patients with both hemorrhage and infarct. And I think that's looking at mobilising within the first 24 hours. And I think that will give a lot more information on actual functional outcomes. But I would agree with you, there's a lot more to life than just measuring middle cerebral artery blood flow. And I think there'll be a lot more information in the next couple of years. Yeah.
Okay, so with this very interesting perspective, I would like to close the session. Just 2 reminders.